So we need to include an internal quality control within the assay. It's really important that any group of patients, 1, 2, 3 patient samples being assayed, we should include alongside those patients a QC sample, an internal quality control, something that we know what is the expected level, and we use that material to confirm that the assay has been successful, it's been accurate, and that the results can be safely released for patient management purposes. Without the IQC, we really don't know that. It tells us we've reconstituted the reference material properly. It tells us that the reagents have behaved suitably. It tells us that there's been a successful assay. So it's really important to include an internal quality control. Very frequently, this is a freeze-dried material, a commercial material, and that's perfectly acceptable, but these work extremely well. It's also possible to prepare locally an internal quality control sample for factor VIII assays. Actually, that's what we do in my centre. And we do that for several reasons. The most obvious might be cost. It's cheaper. But actually, it's not even the main reason. The main reason is that we're able to prepare a control which is quite close in its properties to patient samples. What do I mean? Patient samples are not freeze-dried. They're either a fresh sample which has not been frozen. That will be the case if we make the assay within 4 hours interval between collection and testing. The sample's not been frozen. Sometimes the sample has been frozen if we want to take advantage of efficiencies of assaying several samples together, particularly for diagnostic samples. That might be fine. And we know we've shown for our own method that the process of freeze and thaw introduces no changes in the level of factor VIII, provided, of course, we use appropriate storage conditions. And that really means sufficiently cold. We noticed that the majority of -20 freezers really aren't adequate for storing frozen samples for factor VIII assays, particularly if those are domestic grade freezers. Tempting to use these in the lab, much cheaper than laboratory grade freezers, but they very frequently don't maintain the temperature even at -20. There may be, for example, auto defrost cycles that raises the temperature. You can get partial thawing of samples. That can introduce important differences. So we really need to be sure the samples are stored at a low enough temperature, -35, -50, -70, -80, even liquid nitrogen, -200. All of that, they're all fine, but not -20. So an advantage to a frozen sample for a quality control, we've not changed the properties so much. Freeze drying has the potential to introduce differences. We can change pH and so on, and it's necessary to take steps to prevent that. We don't need to do that in a frozen sample in the same way. The other advantage of a locally prepared internal quality control, a frozen material, to some extent we can select a particular level of factor VIII. And we do a simple thing in my centre. We use fresh frozen plasma. And you're probably well aware that the ratio of anticoagulant to plasma is a little different. It's a little bit more dilute in fresh frozen plasma than is the case in citrate of blood. So it's a little bit more dilute. It means that the factor VIII level in fresh frozen plasma, on average, is at the lower end of the reference range. So typically, if you make a small pool of a number of fresh frozen plasma bags, you might have a factor VIII level in the 50, 60, 70 international units per deciliter range. And we think that's a particularly useful level for a control, keeping in mind that one of the critical levels for diagnosis or for treatment monitoring infusions, would be 50 IU per deciliter. Below this will be time to think about further infusions in a treatment situation, and of course below this increases the likelihood of von Willebrand's and haemophilia and so on. So we think that's an important level for a control in the 50 to 70 range. So we have here an internal quality control sample, and we should treat this now very much the same as the standard material. So same plastic tubes, the same volumes of diluent, the same diluent. Auren's buffer, 900 microlitres, 0.9 of a mil, 1.9 mils, 3.9 mils. We're going to add 100 microlitres to each of those. So 3 dilutions of the control, just in the same way that we made 3 dilutions of the calibration for the initial calibration curve that we'll talk more about later. So 3 dilutions means, of course, three different concentrations, each one containing progressively less factor VIII. Therefore, when we add this to the factor VIII deficient plasma, important to mix, when we add this to the factor VIII deficient plasma, we'll be adding different concentrations of factor VIII. To get good mixing in the larger volume, it's useful to make a tilt. So three different dilutions. 3 glass tubes, same glass tubes as the standard. We're always trying to treat QC and patient samples in the same way, as close as possible to the calibration material, the standard. Same processing, same conditions. So we should add the reagents and so on in the same order. So first, 3 tubes, 100 microliters, factor VIII deficient plasma, from the same pool of factor VIII deficient plasma that we used for the calibration curve. Simply warming up at the moment. Fresh pipette tip for each operation. 100 microliters, 0.1 mil, 1 in 10 dilution. First tube. One in 20 dilution. Second tube. 1 in 40 dilution. Third tube. And mix. In some centres, we noticed from surveys of practice that the quality control material is not assayed at 3 dilutions, but just using a single dilution. I think this is not good practice. And for the reasons that we'll discuss in a moment related to the patient sample, it's really important to do 3 dilutions of the patient samples. And I think in principle, the QC should always be treated in the same way as the patient sample. Then whichever of the conditions that apply will apply equally to both. It's really important to do this. 3 dilutions of patient sample. We need this for several reasons, some of which we'll discuss when we come to the calculations and the plotting of results. We need this to be sure that we meet 2 critical criteria that confirms this is a valid assay. When we look at the relationship between clotting times and concentration, dilution, it should be a straight line relationship. And we can only establish that if we have done several dilutions. If we do 1 or 2 dilutions and we draw a line between, you know that a line between 2 points is always a straight line. So it gives us no information. We need to have 3 in order to confirm this criteria is met. And the second, which again we'll look at when we come to the calculations, the second important criteria for a valid assay, the dose response line for QCs and for patients. These should be parallel to the dose response line for the calibration or standard. Without that parallelism, we have no evidence that the 2 materials are behaving in the same way. Actually, we know if they're not parallel, they're behaving in different ways, and we lose that criteria of a valid assay. So these samples are now to temperature. So we will now add APTT reagent to the first tube, 100 microliters, and mix. Start the stopwatch. 3-minute activation. Second tube, different dilution, different concentration, 15 seconds, and mix. Third tube, APTT reagent, 30 seconds, and mix. Okay, so we know that these tests can be performed with a whole series of different APTT reagents, the same ones that might be used for APTT determination, obviously. And we know that these reagents contain very different phospholipid concentrations. So is that important? Well, it can have an important influence on the results here. Reagents which contain a high concentration of phospholipid are much more likely to be high phospholipid, more likely to be unaffected by lupus anticoagulant, antibodies which block the phospholipid sites where clotting factors are assembled and complexes are assembled. Although the lupus anticoagulant was traditionally described as anti-phospholipid, we now know the mechanisms more clearly. Of course, it's an antibody against the proteins which bind to phospholipid, and some of these antibodies are very different. It's an extremely heterogeneous group. But we know that interference and impact on APTT very much depends on the patients with lupus anticoagulant, but also on the APTT reagent. So there's a big advantage just now if we make the factor VIII assay with an APTT reagent unaffected by lupus anticoagulant, insensitive to lupus anticoagulant. If we do that, we take away this interfering effect. And that can have an important impact on the accuracy and on the precision, but particularly the accuracy of the result. We'll come back to that point when we look at some calculations. So if we use a sensitive reagent, a reagent with a low phospholipid concentration, then we permit much more easily interference from lupus anticoagulant, and that can cause us significant difficulties in the assay. We're running our tests just now in the water bath. Of course, the majority of factor VIII assays worldwide are currently performed on automated systems, and there are many advantages to this. Automated systems usually are a little bit more precise, a little bit more consistent. It's possible to process samples more quickly, so there is less opportunity for change in the reagent system. So there's a number of advantages. And many of these also will allow automated calculation, and that's also an advantage. So now at 3 minutes, calcium to the first tube, start the stopwatch, and mix. 15 seconds, 3 minutes, 15 seconds. Calcium to the second tube, start a second stopwatch, and mix. "30 seconds, 3 minutes and 30 seconds. Calcium to the third tube, start the stopwatch, and mix. So now the clotting is occurring once we've added the calcium. So now we need to again start the observation. The same regular tilting 3 times every 5 seconds through 90 degrees. And remember, this is the quality control sample. First tube clotted. Second tube clotted. Third tube clotted. Excuse me. So 1 in 10, 1 in 20, 1 in 40 dilution. 1 in 10 dilution, 67 seconds. 1 in 20 dilution, 73 seconds, 73.4 seconds. Third tube, 86 seconds. So we've done the standard, we've done the internal quality control. We need to now test the patient samples.